I'd like to talk to you about arthritis of the knee. Typically, a knee is fairly simple. You have ligaments, the medial lateral collateral ligament. You have meniscus. You have the anterior and posterior cruciate ligaments. And then you have the cartilage that coats the end of the bone. This cartilage is typically 5 to 8 millimeters in thickness, and it's made out of cartilage cells. When these cells die, that's arthritis. So this thick surface on the end of the bone gets thinner, and ultimately bone becomes exposed underneath the cartilage surface. We can see the cartilage on an x-ray. This knee to the left, this space between the femur bone and tibia bone is actually the cartilage that coats the bone. These cartilage cells are made mostly of water, so you do not see them on the x-ray. As opposed to the left knee, where all of the cartilage cells have dissolved, they have died, and it leaves the appearance of bone against bone. In addition, osteophytes are formed. This is a severely arthritic knee. This is a mild to moderately arthritic knee on the right side. When you reach this level of arthrosis, there's very little to do to improve the function or outcome of the patient outside of knee replacement or knee resurfacing. The process of this surgery is we digitally size the knee to get the right and correct size of the implant. We then do a spinal anesthetic, a nerve block. These are typically less invasive forms of anesthetic. We do not typically intubate the patient or use a tube. The spinal and nerve block are very good in relieving pain and are very safe for the patient. We then do a small incision. We try to eliminate any damage to muscle. And through that incision, we then shave the end of the bone and cap it. This replicates the lost cartilage surface on the end of the bone. We use this titanium component to cap the tibia bone and insert a polyethylene liner to allow articulation of the knee. We preserve the ligaments, the medial collateral ligament, lateral collateral ligament, and the posterior cruciate ligament. These are all preserved. We occasionally resurface the patella if needed. But in a sense, you can see this is more like a resurfacing of the bone than chopping the knee out. We frequently use robotic techniques to ensure the orientation, the size, the placement of the tibia and femoral component in a position that optimizes ligament balance, range of motion, and stability. Due to a combination of anesthetic techniques, the surgery itself, anesthetic injections we perform during the surgery, medications that we provide, most patients are allowed to go home the same day of surgery. They typically have outpatient physical therapy and have limited restrictions. By 3 weeks, most people are walking normal, they are driving a car, and by 6 weeks are able to do everything they want to do. With that said, this is a difficult surgery. There's swelling, there is discomfort, and sleep can be difficult for the first 6 weeks. There is a wide range of recovery profiles. Some recover quite fast and some are quite slow. But in general, most people are doing well and appreciative of having the surgery within 6 to 8 weeks. Any surgery is a difficult process, and knee replacement and knee resurfacing is a difficult recovery. However, it allows you to get your life back. You're able to backcountry ski, downhill ski, helicopter ski, hunt, fish, hike. Some people run. Some people are able to do many things that they could not do prior to surgery. Overall, patients are highly satisfied with this procedure and are very grateful to have had it done both in pain relief and improvements in function.